Hi, welcome to Dr. Vic's Academy. Today we will be talking about dementia. Major causes. Alzheimer disease accounts for 60% to 80% of dementia cases. Vascular dementia in isolation accounts for 10% of cases, but it commonly presents as a mixed dementia with Alzheimer disease. Lewy body dementia, Parkinson-related dementia, normal pressure hydrocephalus, and frontotemporal dementia represent most of the remaining cases. Risk factors. Older age remains the greatest risk factor for dementia. Other strong risk factors include family history of dementia, personal history of cardiovascular disease, cerebrovascular disease, diabetes, or midlife obesity. Use of anticholinergic medications. Apolipoprotein E4 genotype, and lower education level. Diagnostic criteria. Major neurocognitive disorder requires demonstration of significant cognitive decline in at least one of the following cognitive domains: complex attention, executive function, language, learning and memory, perceptual motor, or social cognition. This decline must be based on both subjective and objective findings, and interfere with instrumental activities of daily living. Minor neurocognitive disorder requires only modest cognitive decline that does not interfere with instrumental activities of daily living. The cognitive decline cannot occur exclusively during bouts of delirium. The cognitive decline cannot be explained by another mental disorder. Initial assessment. A history to evaluate for cognitive impairment should include the input of a reliable informant because patients often have poor insight into their own functional status. The history should include education level, timeline of symptom presentation, and speed of progression. Early in the disease course, dementia often impairs instrumental activities of daily living, such as paying bills, balancing the checkbook, or remembering to take medications. Disease progression may further impair activities of daily living, including difficulty with eating, bathing, dressing, toileting, walking and transferring, and continence. Physicians should review the patient's medications for those that may affect cognition using a resource such as the American Geriatric Society's Beers criteria. Recent hospitalization should increase suspicion for delirium. Physicians should screen for depression in patients who have abnormal cognitive evaluation findings, and should consider evaluating for cardiometabolic risk factors given their association with cognitive impairment. Rapid onset and progression of symptoms of weeks to months increase the likelihood of uncommon causes of cognitive impairment and should prompt subspecialty referral. The vitamins mnemonic: vascular, infectious, toxic, metabolic, autoimmune, metastasis or neoplasms, iatrogenic, neurodegenerative, systemic or seizure or sarcoid is helpful when identifying causes of rapidly progressing symptoms. Although physical examination findings are usually normal in patients with dementia, they can assist in identifying potentially reversible causes of cognitive decline, including hypothyroidism, vitamin deficiencies, neurosyphilis, intracranial tumors, normal pressure hydrocephalus, depression, and hypoperfusion from heart failure. Brief initial screening tests for cognitive impairment. Brief screening tests are useful to quickly assess the need for further evaluation. Available are 3 screening tests that could be completed within the time frame of Medicare wellness visit: Mini-Cog, Memory Impairment Screen, and General Practitioner Assessment of Cognition. These tools require less than 5 minutes to complete, and are validated in the primary care office setting. Cognitive tests for patients who screen positive on initial testing. Patients who screen positive for cognitive impairment on brief screening tests should be evaluated further to quantify the degree of impairment. The following brief cognitive tests have limited sensitivity and specificity, particularly in patients with high intelligence and education levels. They are the Mini Mental State Examination, the Montreal Cognitive Assessment and St. Louis University Mental Status Examination. physicians should consider referral for neuropsychiatric evaluation if a patient has normal findings on brief cognitive tests but cognitive impairment is still strongly suspected. Diagnostic and secondary evaluation. Patients who have confirmed cognitive impairment should be screened for depression, should receive laboratory tests for other common disorders that can cause cognitive impairment, and should undergo imaging of the brain. Routine cerebrospinal fluid analysis and genetic testing are not recommended, but these tests may be appropriate in some patients. Geriatric depression scale. Depression is a common and treatable comorbidity in patients with dementia. Several tools are validated to screen for depression in older patients. The 5-item geriatric depression scale is effective as the 15-item geriatric depression scale and does not require clinician administration. In patients with depression and dementia, treatment for depression should be initiated first. Pseudodementia, or depression causing cognitive impairment, is diagnosed if the impairment resolves with treatment of the depression. Laboratory evaluation. The standard laboratory evaluation for patients with cognitive impairment includes testing for anemia, hypothyroidism, vitamin B12 deficiency, diabetes, and liver and kidney disease. Testing for neurosyphilis and human immunodeficiency virus infection should be reserved for patients with risk factors. Other testing should be based on patient history or physical examination findings. For example, inflammatory markers may be appropriate in patients with symptoms of vasculitis. Neuroimaging. Routine structural neuroimaging in patients with suspected dementia is recommended. Magnetic resonance imaging without contrast media is the preferred imaging test to exclude other intracranial abnormalities, such as stroke, subdural hematoma, normal pressure hydrocephalus, or a treatable mass. Magnetic resonance imaging is more sensitive than computed tomography for distinguishing patterns of regional atrophy and therefore may be helpful in determining dementia subtype. Computed tomography is acceptable if magnetic resonance imaging is contraindicated. In summary, risk factors for dementia include age, family history of dementia, personal history of cardiovascular disease, cerebrovascular disease, diabetes mellitus, midlife obesity, use of anticholinergic medications, apolipoprotein E4 genotype, and lower education level. If dementia is suspected, physicians can use brief screening tests such as mini-cog or general practitioner assessment of cognition. If the results are abnormal, further evaluation is warranted using more in-depth screening tools such as the Montreal Cognitive Assessment, St. Louis University Mental Status Examination, or Mini-Mental State Examination. Diagnostic testing and secondary evaluation, including screening for depression, appropriate laboratory studies for other conditions that cause cognitive impairment, and magnetic resonance imaging of the brain, should be performed when cognitive impairment is confirmed. Routine cerebrospinal fluid testing and genetic testing for the apolipoprotein E4 allele are not recommended.
Audio Jungle. Audio Jungle.